Ethical Perspectives on the News is produced by the Interreligious Council of Lynn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good morning and welcome to Ethical Perspectives on the News. My name is Al Fisher. I'll be serving as your moderator for this broadcast, which is titled The Challenges of Alzheimer's Disease. More than 5 million Americans have Alzheimer's disease. That's 1 in 9 Americans over the age of 65. It is the leading cause of disability in later life, and its care consumes more dollars than any other medical condition, particularly from the Medicaid and Medicare programs. Medicaid costs in the last 5 years of life are 8 times as high for persons with Alzheimer's disease than they are for persons without Alzheimer's. And unless a medical breakthrough is found soon, by the year 2050, the number of Alzheimer's cases will more than triple because of the aging of the enormous baby boom generation and the continued increase in life expectancy. In a recent speech in Cedar Rapids, Matthew Baumgart told the local Alzheimer's Association that this is a public health tidal wave which could eventually bankrupt the Medicare and Medicaid systems within our lifetimes. We have a crisis on our hands, he argued, and it's getting worse, and our leaders and citizens are not taking the necessary action. Here to help us shed some light on these issues are 3 guests. First, Professor Lynda Barrow, a professor of political science at Cole College. Second, Kathy Good, the founder and director of the Family Caregivers Center of Mercy in Cedar Rapids. And Dr. Dan Tranel, a professor of neurology, also a professor of psychology at the University of Iowa Hospitals and Clinics. We'll begin with Lynda about some of the political ramifications of Alzheimer's disease. As both a professor of political science and someone who I know is an advocate for action to combat Alzheimer's disease, what do you think that our audience should know about public policy, how present policies affect Alzheimer's disease and how changes in policy might affect them? That is, what have been some recent legislative wins or victories for organizations like the Alzheimer's Association, and what kind of legislative asks or proposals are being considered on Capitol Hill today?
Well, in the last few years, there have been a lot of legislative wins. A lot of the things that groups such as the Alzheimer's Association have been lobbying for have been, in fact, enacted. These include things like the National Alzheimer's Project Act, which is known as NAPA. And one of the things that this mandated was that there would be a strategic plan in the country for dealing with Alzheimer's. And it also said that the National Institutes of Health would create an overarching budget. And it put together that budget saying that they would need $2 billion in research funding if they were going to reach the national goal. And there's widespread agreement. Basically, the federal government and the Congress has bought into the idea that the policy goal, or the health goal as well, is to be able to prevent and cure Alzheimer's by 2025, which is, of course, coming up very quickly. And then the following year, in 2012, the national government created the first national plan to address Alzheimer's, and again with the idea that the goal is preventing and curing it. And then following, there was an amendment to a bill that essentially said what the National Institutes of Health is going to do is not wait for the federal bureaucracy to essentially say we're going to put together this budget. They go directly to Congress and say, if we're going to reach this 2025 goal, this is how much money we need this year. And what we have seen since then is that there have been big increases in funding, starting from a very small amount. But in 2015, there was a hike of $350 million. There was an even bigger hike the following year, 2016, of $400 million. And now associations such as the Alzheimer's Association and following the NIH are suggesting that we need $414 million. And the thing in here is, if you look at the leading causes of death in the United States, funding for research on Alzheimer's has been disproportionate. We've had lots of funding for other major killers such as heart disease and cancer, HIV/AIDS, and it's paid off. In the last several years, mortality rates in those areas have dropped. Meanwhile, Alzheimer's has jumped by leaps and bounds up to, it was an 89% jump. And the predictions are that's it's not going to get better. In terms of the number of people who are going to be affected, the baby boomers coming of age, I'm at the end of that, so I'm among those. In terms of the soaring costs, financial costs, emotional costs, psychological costs, costs that are predicted to perhaps break our healthcare system. You mentioned a tidal wave, others call it a tsunami. And then the fact that of the major killers, it's the only one that cannot be prevented, slowed, or cured. There's really nothing out there right now that has proven effective.
We'll return to some of these topics a bit later when Dr. Tranel will speak about the current status of research on Alzheimer's disease and whether we see some glimmers of hope. Kathy Good, the organization that you recently founded is dedicated to meeting the needs of persons who provide care for people with diseases like Alzheimer's, especially to meet the needs of family members, since they provide far more of the care than institutions do. What are some of the difficult challenges that caregivers face in health, in finances, in their careers, and what resources are available in our community to help caregivers cope with those challenges? Are there ways that care for Alzheimer's patients can be provided in the patient's home rather than in an institution?
Let me talk a little bit about some of the financial and the physical or health and the psychological kinds of issues that caregivers face. First of all, let me deal with the financial. And what we know is that statistics tell us that 71% of caregivers make some sort of changes to their work in order to care for their loved one. And there's a cost to employers that's huge. These are old figures. I took them out of the National Academy of Sciences 2016 report on families caring for an aging America. But they said these statistics are old, and they said it was estimated that the cost to employers is 29 to 33 billion annually. So that affects all of us, obviously. 47% of caregivers use most or all of their savings due to caregiving. I was really fortunate in my dealing with Dave, who had Alzheimer's for 12 years, in that I was my own employer. I had my own counseling practice, and so it was easier for me to be able to just decide that I could take and see less clients. So I didn't have to convince an employer that I needed time off or that I needed to reduce my hours or have flex time. I could just simply do it, and we were thankfully fortunate enough that we had some means. Our income was cut in half when Dave was diagnosed with Alzheimer's. In terms of health, what we know is that more than 60% of caregivers are at a higher risk for depression, illness, and accidents than the general public. 63% 63% of Alzheimer's caregivers have a higher mortality rate than non-caregivers. 41% of Alzheimer's caregivers die from stress-related disorders before the person living with Alzheimer's. And the stress of family caregiving for a person with dementia has been shown to impact a person's immune system for up to 3 years after caregiving ends. In my own case, Dave was diagnosed with the visual variant of Alzheimer's in 2003. And by 2011, I was living with compromised vision in both eyes and rheumatoid arthritis, all of which were stress-related diseases. And so somebody might say to me, well, how do you know that was related to Dave's caregiving? And I'd say, well, if you lived in these shoes, you know that was related to the stress. In terms of psychological kinds of issues that present to the caregiver, I think that the Alzheimer's disease is confounding to caregivers. And my experience tells me that caregivers don't turn off their problem-solving portion of their brain until the person dies. Because you're constantly, no matter what you're doing, you're trying to figure out, was that what I should do, or is there something else I could do? And even if there was something else I could do, I can't figure out what it is. And so it's just a constant kind of stress that goes on. Inherent in being a caregiver of somebody with Alzheimer's or some form of dementia is loss. And Pauline Boss, who's a noted author, has come up with the term ambiguous loss. And it really fits for caregivers of people with Alzheimer's because the person is here and not here. So they're here physically and they're not here cognitively. And so somehow the caregiver has to figure out how to deal with that ambiguity and with the loss at the same time that they have to continue to physically care for the person. I was a counselor in private practice, and after 8 years, I sought out counseling because it was so confounding, and I thought I needed somebody. I found a mindful grief counselor who helped me live in the present moment, because in the present moment I wasn't doing all the what if thinking, well, what if, and creating anxiety on my part, because I used to say, well, maybe I'll get hit with a Mack truck and I won't ever have to worry about those what if things. But it was really good to learn to kind of live in the present moment. In terms of resources, I think, of course, because we've started the Family Caregivers Center of Mercy, the reason that it was started was Tim Charles, as the president and CEO of Mercy Medical Center, was at the time and continues to be about this tsunami of Alzheimer's, people that are going to be diagnosed with Alzheimer's, and feels like the medical community is not prepared to deal with it. And so, but figured if we could establish a caregiver center, then at least we would be able to provide support for those family caregivers, emotional support, help them figure out what their needs are, help them get connected to community resources that can be of help to them. When Dave was at home, I created what I called my committee. So I figured out our needs, I figured out, what community resources existed, and then how to access them, fill out the forms, determine your eligibility, and manage the committee. And so, and I felt like that was a challenge, that it took all of my social work skills that I'd learned all my life. So there are resources. There's the Alzheimer's Association, there's the Heritage Agency on Aging, there's Aging Services, there's palliative care at both hospitals. There is an array of non-medical in-home care providers, and I think that the effort is to make sure that we've exhausted all of the in-home kinds of care before you seek out-of-home placement.
I found the idea of having coaches coach other people very, very useful.
Yes, well, and that's really our model, is really a peer support model. So at the Caregivers Center, we're not holding ourselves out as experts, but we are people with long-term kinds of experience as caregivers, willing to share that with other caregivers. The things that worked for us, the things that maybe hadn't worked so much for us.
If I could just add something, you mentioned palliative care. One of the things that a number of Alzheimer's groups would like to see in addition to increased research funding, and there's a bill out there that they keep hoping will get passed, is more and better training in palliative and hospice care.
Right.
So that those who are being taken care of are really getting the quality of care that they need.
Yes, well, every caregiver that comes through our doors is really a candidate for palliative care because they're dealing with long-term chronic kinds of conditions.
When you were talking about some of the physical symptoms you began to develop as a caregiver, I was reminded of what I think is a key point, that both caregivers and people with Alzheimer's often have other serious conditions at the same time. And I'm reminded of a close friend of mine from my church whose wife died last year after a 10-year siege of Alzheimer's. My friend said he was stunned when he received the death certificate, and on it, for the cause of death, it gave a heart attack.
Yes.
And he said, well, the real cause of death, arguably, was her Alzheimer's disease. So he has written a lot to the CDC and talked to some people there saying, isn't there a possibility that calling Alzheimer's the sixth leading cause of death is an underestimate of how many lives it actually takes?
There were a couple of studies done in 2014 that suggested that, in fact, Alzheimer's may be the third biggest killer after heart disease and cancer because of the underreporting.
Well, and what's significant about that is that research money is designated based upon the ranking of the significance of the disease. So if Alzheimer's is underreported, as our friend Ken Kirby said, and he's right, then it leads to less research dollars.
Dr. Tranel, what kinds of research are going on today that might eventually show some promise of producing a breakthrough in either preventing or at least ameliorating some of the symptoms of this terrible disease? And I was struck, as I imagine you have been, to see that in view of the massive spending on Alzheimer's for healthcare, that for every dollar that the National Institute of Health spends on research on Alzheimer's disease, government spends $300 on health care for people with Alzheimer's disease. So in view of the massive spending on the care of people with Alzheimer's, why do we seem so reluctant, at least until these significant infusions of research money, to spend at least as much money on Alzheimer's as we do on cancer or HIV/AIDS or heart disease and stroke? So can you give us some hope, given your view of the current state of Alzheimer's research?
I'm not sure I can answer your question about the reluctance part of that, other than the fact that there's limited resources. But yeah, to start sort of a while back and work up to the answer to your question. We've been working on this disease and the biology of it for decades. In fact, my colleagues and I in the Department of Neurology discovered in the early 80s some of the cellular loss in the brains of Alzheimer's patients who had come to autopsy, and the destruction of these very specific cell layers in the hippocampus that was correlated with the memory impairment that's the hallmark clinical manifestation of the disease. We published a paper in Science in 1984. I mean, that's more than 30 years ago.
Right.
And that, there have been just, there's a mind-boggling number of studies done about the biology of the disease. And here we sit in 2017 with no long-term treatment that produces meaningful change in the patients or their families. I mean, the changes that those patients or their families would tell you are meaningful improvements. And that is just a staggering situation. And it's, you know, it's not from lack of trying. There have been hundreds and hundreds of drugs that have gone through trials, and this leads us to questions which, you know, are kind of in the headlines of the scientific you know, world that's working on this problem. You know, what are we doing wrong here? Are we studying the wrong biological substrate? Are we studying the wrong people? Are we using the wrong drugs? Are we going about this wrong? You know, why have all of these things failed so badly after decades of research on this? And then, of course, this problem is, you know, just hugely, you know, compounded by the, as we mentioned, the baby boomers and this tsunami of what's coming ahead of us in the next couple of decades. I mean, any way you spin these numbers, they're just staggering. So, where are we at with the science? I think there's, you know, the scientists agree that there's a huge need to move the whole, you know, spotlight of our inquiry earlier in the process. When people come to the clinic with a memory problem, it's too late. And we need to be identifying people at risk earlier in the process, before they're symptomatic. And I think there's a widespread agreement that we need to identify biomarkers, basically, you know, biological things that you can measure that might be risk factors or might be indicative of carrying the disease early on in people before they're symptomatic, to have a chance of intervening and getting to a goal like prevention or cure. Those prevention and cure goals, I think I don't think those goals are realistic if we're working with people who are symptomatic. We have to move that window earlier in the process. So I think the science is, you know, strongly moving in the direction of earlier in the whole process, pre-symptomatic. I mean, not even people with so-called mild cognitive impairment, but people without symptoms yet, who might be at risk because of whatever it is they're carrying, genes, lifestyle things that have happened, et cetera. And then trying to do, you know, population level studies that can identify biological targets in those people that could be potentially modified. So if we could identify biomarkers in people at risk at an earlier stage, I think we would have a chance to develop a treatment that might, you know, prevent the disease, slow down the course of it, that kind of thing.
There is the enormous brain health registry. They're trying to get 100,000 participants and map them over time, and I wonder if that's precisely what they're trying to do, to get people who are not yet symptomatic at all.
Yep. Yeah, that's on the same theme. And you know, the issue that this gets to, which Lynda brought up and Kathy brought up and you brought up, Al, is you know, this whole endeavor is just badly under-resourced in terms of the money that's being spent on the science. These kinds of studies are, you need very large ends. You need longitudinal studies that have to take place over decades. Drug studies take a long time to, you know, really study a drug carefully in a large population. There's so many, it's such a complex disease with so many factors that modify, you know, how it's expressed and the course of the disease and the nature of the symptoms that people have, that, you know, for science to work well, you have to have large numbers of people studied over a long period of time. That takes a lot of resources.
And
brain science is complicated.
Politically, at least, people have woken up to the idea.
Yeah.
that a lot more research funding is needed. So
Yeah.
in this era of hyper-partisanship, this is an absolutely bipartisan issue.
Absolutely.
When bills are passed, there's almost unanimous support for them in the Congress.
Yeah. But as Lynda mentioned, I mean, these numbers, we can't have numbers that have an M, something million. It's we need to be there.
Right.
Something
Bs.
billion.
2 billion, yes.
You know, to get up to the level, you said it well, that we're nowhere near the resources they've been putting into cancer and HIV, let alone, building helicopters to blow things up and et cetera, et cetera.
So if I follow your argument, Lynda, you're saying that even if there were proposed large cuts in the National Institute of Health, that ultimately such programs, such agencies would survive because of a wide and deep and strong base of support? Because right now there seems to me to be a pretty strong anti-science animus in much of Washington.
Right, and the Trump administration just today came out with their budget that suggested that NIH was going to take a big hit. I presume that does not include Alzheimer's research. However, it might well mean that research does not get the increase this year that it needs. And you mentioned one set of figures, but another set of figures of the disproportionate money going into this research is that essentially for every $160 Alzheimer's is costing our country, we're giving 1 penny in research.
Okay.
It's now costing us $259 billion a year. That's what this disease is costing our country alone.
Al, if I can jump in with
Certainly.
I like to use this example to get to the sort of the science issue. The light bulb was not discovered by incremental improvements on the candle. Some guy wasn't sitting there figuring out a way to make candles gradually better, and then it became a light bulb. And that underscores the need for discovery science.
Right.
And we need to fund discovery science. And there's a lot of emphasis in the NIH system, in peer review. It's very conservative, and it's all incremental and just these very small changes, and we need to fund, innovative, imaginative science that's out of the box. I mean, you read these articles, and every one of them says, we don't have a paradigm. We're doing the wrong things. We don't have a framework for this. And we need really smart people to be given enough money to sit around and think about this and then do something innovative. Not very conservative science that just barely nudges things along.
We have only about a minute left, so I'd welcome some quick closing statements if you have them.
Well, tsunami is the word that Lynda used, and I would totally agree with that. I mean, this baby boomer thing, it's hard to fathom how people are not seeing this coming at us.
Yes, we've seen the basketball going through the snake for a long time.
Yeah, exactly. And this disease, I mean, you're talking about such a protracted period of time.
Right.
In the neighborhood of a decade on average, and the caregiver stress that's enormous. So I think we need a short-term infusion of resources that has a lot to do with things like caregiver burden and dealing with symptoms. And we need a longer-term infusion of resources in terms of the science.
Okay. 30 seconds, either of you?
Amen. That's what I would say to that, yes.
Well, thank you very much for your insights. This has been a most illuminating discussion. Thank you.
Yeah.
Thank you.
Thank you.
Thanks.
Thank you for tuning us in this morning.